and welcome to the Geary Institute for Public Policy seminar series, the start of a new term. My name is Niall Collins, one of the social policy academic, one of the Geary board members. I'm going to start with an apology to my colleague Macken, who is the organiser of the series but can't be with us today. Lots ahead over the 2 terms, and we'll keep you posted on all the information. But to start the session this year, I want to welcome Anthony Macken, who is the head of the CSO's Health Research Data Centre, and his colleague Stephen Lee, who's a statistician for the Irish Health Survey, and they're going to talk to us today on the CSO's health research data and linking health microdata for researchers. So, gentlemen, you're very welcome.
Okay. Thanks very much, Michal. Hi everyone, I'm Anthony Macken, the head of the Health Research Data Centre in the CSO. I'd like to thank the Geary Institute for having myself and Stephen here today. Particularly Michal, Michelle, Doran, Juliana, Chris as well, as a lot of people involved in making this happen. And it's great to be here and to be able to let you know what we're doing in the CSO. Initially, I'll start off with a single sentence, and it is: the CSO is uniquely placed in legislation to facilitate safe researcher access to safe linkable microdata sets for health research purposes. And as we go through the talk over the next 20-25 minutes, hopefully this should all become clear, and pretty much everything we'll look at today will be centred around this. To give you a brief history of the CSO Health RDC, its beginnings go back to 2020 during the pandemic, when emergency access was set up to COVID-19 data. This was done as a collaboration with many different organisations. You can see them listed there. And what it was is we provided emergency access to IMAG, which was a modelling advisory group that was a subgroup of NEFIT at the time, the Public Health Emergency Team. About a year later, we extended this access beyond the emergency team to allow for researcher access to COVID data. That was called the COVID-19 Data Hub in the CSO. And beyond that, I don't know if there's an official end to the pandemic at any point, but we had lots of governance and structures put in place to allow for access to health research data for the first time in the CSO. So we gathered our other health research data sets together and continued to use the governance we had in place for COVID-19 access. And this became known as the CSO Health RDC and was launched in November 2024. And what it is, it's a safe space for access to safe data collected by the CSO for health research purposes. I'll go into the meanings of safe later on. It's to do with access and the review process we have in place. Its operation is underpinned by GDPR, the Statistics Act 1993, the Data Protection Act 2018, otherwise known as the Health Research Regulations. And there's more detail on that available in the CSO Transparency Notice on our website if you'd like to have a look. Just to get into more of the detail then, these are some of the data sets available through the Health RDC. The data sets on the left are the Irish Health Survey. So the data sets on the left are the ones that are connected to our health research data sets, or loosely connected to health research. We've got the Irish Health Survey, the Primary Care Reimbursement Service, TILDA, which is the longitudinal study on ageing in Ireland. And that isn't in the CSO yet, but it's due to be coming into us in the next 6 months to a year. We have vital statistics for deaths information, and there's COVID data as well. The data sets you see on the right, census, growing up in Ireland, labour force survey, the survey on income and living conditions, and there's also administrative data such as revenue and welfare and many more. These are all linkable to the data sets you see there on the left, and that's sort of key to how this all works, because as you know, there's a certain amount of information you can get from a single data set, but there's far more insights to be gained when things are linkable, and you can discover the value of one through another. At this point, I'm going to hand over to Stephen, who's going to talk to you about the Irish Health Survey.
Thanks, Anthony. So one of those surveys here you see is the IHS, or one of these data sets, which is the Irish Health Survey. So I'm the statistician responsible for the Irish Health Survey. And I'm just going to give a brief overview, just a few minutes of what it is and how it might be useful to researchers. So it first ran in 2015, again in 2019 and in 2024, and from last year it's going to be an annual survey. So it's basically, we ask over 100 questions all about people's health, their self-perceived health, health determinants, healthcare utilisation and their status, which I'll go through a bit later. And this data set is available anonymised for researchers to access in the CSO. How we choose this survey, the sample frame, so we choose it from census, so the last census in 2022. So everybody in that in the census has an identifier, CSO identifier, and using that identifier you can link lots of other administrative data onto the survey. Questions we don't ask, so you can find out people's income, you can add that on. You can add on, like prescription data, see what prescriptions they're on from the PCRS, you can add that on. So it's really, really useful data set in that way. Just to give you a flavour of what's involved, so our last publication was the Irish Health Survey in 2024, and this is the infographic we published on our website. So it kind of gives you just a quick snapshot of the main features of the survey. So, we asked people's self-perceived health to be good or very good, and we got 77% of 18 to 24-year-olds who said yes, and 62% of age 75-year-olds. So, as I said, we ask over 100 questions in the survey. It's a web-based survey, an online survey. So it's all done very scientifically, a random sample from the census. And again, we can do like proper weighting and calibration and everything like that. So like you can be sure you're getting good quality data there. Over 100 questions, it's 3 blocks of questions basically. So you have the health status, which is self-perceived general health. We ask about diseases and chronic conditions, if you have any and what are they. We ask about neurodiversity, so if you have autism, ADHD. If you have any limitations and difficulties due to these problems and chronic diseases, barriers to participation in society or with your social life, or if you're in pain, and also we ask about mental health. So this is just one chart we published. Self-perceived general health of all persons aged 18 years and over by age group in 2024. So as you can see, like 18 years and over, so is everybody is about 75%, as I mentioned earlier, are in good or very good health. But interesting here, the 18 to 24-year-olds seem to have lower good or very good health than the generations preceding them. So that's kind of an interesting thing there. I think, when you're looking at this, you might spot things like that. You say there's an area of interest for research, what's going on there. You can then link some administrative data like prescription data to this, or you can look at maybe autism data and see what's going on there. We don't delve that deeply into it ourselves, but that's kind of more researchers will be interested in doing that. We also ask about healthcare utilisation. So it's all about if you've been to hospital, how many days you were in hospital, use of long-term care services, use of home care services, what medicine you're using, and also very important if you have any like delays in getting appointments, so your unmet needs. So this is just a graph we published from that. It's just the number of consultations with medical professionals in the last 12 months. So as you'd expect, GP consultation is the highest, followed by dental, and then, as I think we all know, women are more likely to go to the doctor than men, and that bears fruit in this data. So the final section we ask is about health determinants. So we ask, these are indicators of people whether they may, can kind of predict what kind of health they have, whether it's good or bad. So your weight and your height can be used to calculate your BMI. So social media use, which is particularly relevant for younger generations, I think. Amount of exercise you do, if you're smoking or if you have alcohol, if you're drinking, how much drinking you're doing. Lots of stuff there as well. So here's the chart we published from that. So this is the number of drinks you take in a week. So drinks alcohol weekly, less than weekly, or does not drink alcohol is the yellow bar. So we can see like there's kind of a narrative at the moment that young people aren't drinking as much as their elders, and we kind of see that here. The 18 to 24-year-olds are are drinking weekly the lowest amount, we'll say. So it'll be interesting over the next decade or so to see if that trend, if they keep that trend or if they just start drinking more like previous generations. But interesting area of research. You know, you could kind of link this to prescription data again, or you could link it to, you know, other stuff like income and all that. See, why are they not drinking as much, you know? So our future plans for the survey, at the moment the survey is there on its own, like the hundreds of questions are just there for researchers, but we do plan to add data to it. So we do plan to add income from administrative sources. So we have that from revenue, like your weekly pay slips and self-employed income. So we can add all that on per person with our unique identifier. We can add on the prescriptions that people are taking, as well any data that's in the census, such as small areas. So you can look at the health of people maybe in cities, urban versus rural, or people living around a hospital or further away from a hospital, things like that. Here are just some links if you're interested. If you just basically Google EHIS, that's the European version of the survey, which our survey is based on. If you just Google that, you'll find all the information you need, or if you Google Irish Health Survey, it'll bring you straight to the CSO website as well. And my email address is there as well if you have any questions. So I'll hand you back to Anthony.
Okay, thanks, Stephen. So normally giving a talk like this, statistician Tomás Kelly would present the next section. It's on PCRS and mortality indicators. Tomás is the statistician for the area and he's an expert on it. I am not. So he left me a few notes anyway. So I'll go through, there's only 2 slides here, but I'll give you some detail on the area. So mortality indicators by ethnicity and deprivation. So it's possible to generate these indicators through linkage of the census analysis dataset, vital statistics, cause of death data, and deprivation index. Sorry, he gave me good notes, I just have them in the wrong place. So you can access this data through the Health RDC to begin with. I know Stephen talked about the CSO not delving too deeply into some of the data we supply or provide, and that's just the way it is due to resources. To give you an idea, there's over 700 variables in the census, and there's 5 million entries in the census data set. There's 1 entry then for every death registered in a year, looking at the cause of death data. And cause of death data is classified according to ICD-10, that's a coding used. And with that, there's about 30,000 entries per year for cause of death data. You've got 30,000 entries for cause of death, so 700 variables in census with 5 million entries. So the potential just for linkage there is huge, and it's not something the CSO can fully explore. We can take any census attribute and link it across to other data sets. So the obvious ones I suppose we'd speak about would be ethnicity, deprivation, but for example, if you wanted to see if there's a link between the mode of transport people use to getting to work and the general health, that can be done as well. Through the census we can see whether people cycle, take a bus, and go to school, work or college, and you can link that using a CSO identifier then to the PCRS data to see what medication they're taking, their self-reported health status, all of it's there. If the slides are made available to you afterwards, there's a link there to tables on the CSO website that include mortality rates and the number of deaths. So these tables are broken down by age, sex, ethnicity, and age, sex, and deprivation quintile. Okay, with the PCRS then, we'll look briefly at this as well. There's an upcoming publication which will provide insights into medication usage. It's built upon ATC codes. ATC codes are anatomical therapeutic chemical codes. So the PCRS, it's a data set which is available through the Health RDC. Publication illustrates only a small bit of the potential of the data set. The publication explored things such as overall PCRS activity, the number of prescribed persons by ATC code, the number of medications taken over the year co-prescribed ATC codes, and medications taken in the year before death, I said their ATC code is anatomical, therapeutic, chemical codes. I think there's 4 top-level codes, and they're broken down then into more and more detail as you go down, all the way down to chemical compounds. There's huge potential to give us insights into the health of the population, and this data is available from the years 2016 to 2023 each year. Okay, so we'll move back to the slide that I left you on before Stephen spoke then about the Irish Health Survey. So looking further at these here, I'll give some examples of projects and linkage potential for what's going on at the moment. So using vital statistics, cause of death data can be linked to the census, as you know. With PCRS and vital statistics, if you can link medication to a certain condition, you've got comorbidity then, and further exploration can be done. PCRS can be linked to socio-economic data, for example from census, and then if you look at the Irish Health Survey, this is linkable to PCRS, vital statistics, social welfare, etc. So the potential there is to do all sorts of matching. I should just mention as well, with the administrative data sets, these are the ones that the CSO doesn't collect from surveys, such as PCRS, COVID data. These are only given out on a sample basis, so you get access to 10% of the data set we have. And this is for statistical disclosure control purposes.
Well, that's true across the CSO, right? If you were getting something from revenue, I've been told the same thing. If you want to get data on earnings, again, it would be at 10%.
For sure, yeah, with revenue data, yeah, 10% max.
That's
yeah,
right.
yeah.
I ask, if you're linking though the admin data to one of the other surveys,
Yeah.
the Irish, the IHS, do you get data on everyone in IHS? So that would be less than 10% of the admin data.
So if you're going down that route, you'd have to put a fairly strong business case together to be able to get access to. Maybe there's ways to do it. So say if it's the Irish Health Survey, and how many respondents do we? About 8,000, is it? 7,000. And say if the link was made, and if you're given 10% after the 7,000 link, you're not going to be able to extract too much value from that. Then, if you're only getting access to 700 respondent data.
You would only get 700?
I'm not. No, that's not what I'm saying. But I wouldn't say outright that we give you access to all of the data.
Oh, okay.
But if a good business case is made to demonstrate why it's necessary to get the full amount, it makes it easier. Yeah. And I'll go into further detail about that in a couple of minutes as well when we look at the review process. Examples of current projects being undertaken at the moment. There's one to identify the prevalence and impact of comorbidities in people with diabetes in Ireland. And that project is using PCRS, 2016 and 2022 census data and death registrations. There's another project looking at the impact of smoking on Irish mortality. It's using data from the census 2022 matched with deaths data from 12 months subsequent. It's also including smoking status, age, gender, socio-economic status and health status. So to give you an idea how that survey has been conducted, a researcher is getting access to census data that was gathered on census night in 2022, and then they're getting access to vital statistics data, or the cause of death data, for the subsequent 12 months. They can examine the results of the census, see people's self-reported health status to say like how they felt then, how their health was, and then look at vital statistics for the following year to get further analysis from that. There's a third project on which is aiming to understand the disparities in diabetes medication prescribing. That's looking at PCRS, census, and a deprivation variable. Okay, so getting to the process then, if you have an idea, if you're thinking this is something you might be interested in applying for access to, in its simplest form, then this is the application process. You see on the top right there, there's a box saying researcher and organisation registration with the CSO. UCD, or the Geary Institute, is already registered, so you wouldn't have to go through the researcher organisation registration, but you would have to register as a researcher. This is just to demonstrate to the CSO that you're competent in the use of statistical software, you understand statistical disclosure control, and there is a brief training, online training course as well, where you'd be shown the importance of protecting the confidentiality of CSO microdata. The 3 boxes then you see within the rectangle in the centre are 3 necessary steps for access to data for health research purposes through the CSO. Ethics approval must first of all be sought and granted. That's done from UCD, so it's the researcher's own institute that grants that. HRCDC stands for Health Research Consent Declaration Committee. And in these cases, we're supplying access to data where consent wasn't initially given by the patient in these cases a lot of the time. So consent is given via an external method, and that's the Health Research Consent Declaration Committee. That's necessary under the health research regulations. The RDGB, it's the Research Data Governance Board. It's an independent group set up by the CSO and the Health Research Board, which has gone back to the COVID days. We've carried this forward, and this reviews all applications coming in for access. When we have those 3 approvals in place, final approval or final review is carried out by the Director General in the CSO, and where approved, access is granted. What makes it safe is, just illustrating using the 5 safes here, is safe people, that are the researchers accessing the data who've gone through a registration process, safe projects that have all undergone ethics and consent reviews before coming to the CSO, safe settings is the technical settings we'd have in place. Safe data is the treatment given to the microdata before it becomes available to researchers. For example, all direct identifiers are removed. And safe output is the output checking process that takes place at the end of the process then to ensure that nothing disclosive leaves the CSO. I spoke briefly about the RDGB, the Research Data Governance Board. It's an independent review board that is an additional governance measure onto the CSO's normal review process, and its role is to assess the feasibility of the project with available data, among other things. All members are experts in health research, and they meet monthly. There's publicly available data on these meetings on the CSO website as well. With the Consent Declaration Committee, as I said, our explicit consent is mandatory safeguard under the health research regulations. So where we don't have explicit consent, this is where this comes in. And the HRCDC will grant consent when it's satisfied that all data protection safeguards and technical and organisational measures have been met. And they'll be dealing with my side for that. And then from the researcher side, they'll be looking at the public interest. They'll be looking to see that the public interest in carrying out the research significantly outweighs the public interest in requiring explicit consent, which in almost all cases would be impossible to obtain. The security that we have with our systems in the CSO might be typical to how you log into your own systems here. It's a username, password and PIN, 2-factor authentication. It's a lockdown system, so it's not possible to import or export any data from it without the say-so of the CSO. The administration of access and expiry of projects are all automated now, and all outputs are checked prior to being exported at the end of the project to a researcher. In terms of the policy and legal side of things, access to the Health RDC is underpinned by our RMF policy, that's the Research Microdata Files policy, and the legal framework then under which access to RMF is granted is Section 20C of the Statistics Act 1993. If you sign up to this, the last thing you'll do before you get access is sign an Officer of Statistics cert, which contains a declaration of secrecy under Section 21 of the Act, and you're obliged by law under Section 33 of the Statistics Act to respect the statistical confidentiality of information contained in the RMF. Every Officer of Statistics, every appointment is for a specific person, for a specific project, and for a specific period of time. So there's no cases where you get access to a project with a vague project title and it's until you're finished with it or anything like that. And for that reason, I suppose there aren't many happy accidents when you're carrying out research. We're looking for people who have a specific thing in mind, a specific question, and they're looking to address that through the research for a specific period. Any breach is an offence under Section 38 and may be subject to prosecution. Okay, that's that section done with now. It's probably the worst of it. The software you get access to within the system is R and R Studio, Stata, SPSS or QGIS. QGIS is a mapping software used by people working in infrastructure projects. Secure remote access, and the data remains on a CSO server at all times. Generally the software is updated to the latest available versions as well. So we're finishing up now. This is the analysis outputs. So SDC, Statistical Disclosure Control, must be applied to the outputs. The researcher has a legal obligation, I've said this a few times now, to protect the data confidentiality, and only aggregated and safe outputs can be released. So going back to the first slide, I think was, I'll say it again, the CSO is uniquely placed in legislation to facilitate safe researcher access to safe linkable microdata sets for health research purposes. And that's kind of what I hoped that was all about there. So if you're interested in learning more about this, if you have any questions after today, you can contact me via healthrdc@cso.ie. I'm happy to have a call with anyone, do video calls. We can set up calls with people like Stephen here or Tomas, who are experts on the data sets, who can talk you through what exactly can or can't be done if you're not sure yourself. I can talk you through the application process at any stage, because there's a lot of different steps involved. I think that I did say in its simplest form when we were at that particular slide, there's about 7 boxes, but like the flow chart is horrible if you saw it. It doesn't fit on screen. Yeah, and that's really it there. We can give you guidance on using the system as well if you do get access eventually. So like we can help you out with any aspect of this, and we're really looking to get people using the data that we have available, because we don't have the resources to do everything that should be done with it. So that's it. If there's any questions, we'd be happy to have a go at answering them.